Dr. Ryan here, board certified specialist internist. Thank you so much for joining me today, even as we look at an examination approach to a patient who has dyspnea, a very common clinical presentation. If you haven't yet subscribed to my channel, what are you waiting for? You know the song, Take My Breath Away. I think that's quite appropriate for our clinical topic today, dyspnea. So as always, when we're examining the chest, there are a couple of certification points. Right? First up, is the patient hyperresonant, or is there bilateral basal dullness, or is there unilateral basal dullness? This is, of course, on percussion of the chest, right? So if the patient's hyperresonant, there's two possibilities, emphysema or asthma, and you also find that the breath sounds are bilaterally reduced. Or pneumothorax, in which case there's ipsilateral absence of breath sounds, and if under tension, you may have tracheal deviation with hypotension. But if the patient has bilateral basal dullness, you're thinking, okay, is it cardiac failure, in which case you'll have stony dullness on percussion with a raised jugular venous pressure? Is it advanced cancer, in which case it'll be the stony dull with a normal JVP? Or is it pulmonary fibrosis, where you find the typical end expiratory Velcro-like crepitations with diminished expansion? If there's unilateral basal dullness, you're thinking, is there an effusion, in which case it will be stony dull, and you may have an aspiration mark from a previous pleural tap. And that, as we know, you use Light's criteria and certify that into the different subcategories. Is there empyema or a subphrenic collection, in which case, you have dullness and fever in that area? Is it lobar pneumonia, where you have bronchial breathing and fever accompanying the dullness? If you have clubbing, you must think, okay, is there lobar collapse, is there phrenic nerve palsy, is there pleural thickening, is there massive HEPA? Previous lung resection, the big tip off there is thoracotomy scar. Right? So quick fire again, guys. In the patient who is dyspneic, you percuss the chest and find if you're hyperresonant, if you have bilateral basal dullness or unilateral basal dullness. If you're hyperresonant, the possibilities are emphysema, asthma, pneumothorax. If there's bilateral basal dullness, are we dealing with cardiac failure, advanced cancer, or pulmonic fibrosis? If there's unilateral basal dullness, if it's stony dullness and effusion, or it could be an empyema or a subphrenic collection, could be a lobar pneumonia if it's just dull, right? Or it could be lobar collapse, phrenic nerve palsy, pleural thickening, or massive HEPA, or lung resection. Alrighty. So just in general, going through lung disease. Now remember, from a conceptual perspective, all lung disease is either one of consolidation, effusion, fibrosis, cavitation, or suppuration. Cavitation, effusion, fibrosis, cavitation, or suppuration, right? One of those, or collapse, right? So just get my pen in there. If a patient presents with consolidation, you find that the mediastinum are not usually displaced, but chest valve movement is reduced over the affected area. Percussion note is going to be dull, not stony dull, just dull. You have bronchial breath sounds and you have crackles, right? That's consolidation. If there's collapse, you may have ipsilateral shift, pulling the trachea towards that collapsed area. Chest valve movement is diminished over the affected area. Percussion note is dull, breath sounds are absent or reduced, and added sounds are absent. Collapse, another word for that is atelectasis, right? Pleural effusion, you find the heart is often displaced to the opposite side, and the trachea is displaced only if massive, right? However, if you have an underlying mass below that effusion, you may find the trachea may be pulled towards a massive effusion, and that is the diagnosis of exclusion. Chest valve movement over pleural effusion often reduced over the affected area. Percussion note is stony dull. Breath sounds may be absent over the fluid, maybe bronchial at the upper border. Added sounds are absent, and the pleural rub may be found above the effusion. What about pneumothorax? We find tracheal deviations the opposite side if under tension. Chest valve movement is diminished over that affected area. Percussion note is resonant. Breath sounds are absent. There are no added sounds. In bronchial asthma, there's usually no mediastinal displacement. Chest valve movement is decreased symmetrically. Percussion note is normal or decreased. Breath sounds are normal or reduced, but the key there is expiratory, sometimes even inspiratory wheeze. In interstitial pulmonic fibrosis, we find that the mediastinum are not usually displaced. Chest valve movement is decreased symmetrically, but minimally so. Percussion note is normal and unaffected by cough or posture, because if your percussion note is affected by a cough, or if your crackles are affected by cough, that implies a problem in the airway. But pulmonic fibrosis is a problem in the parenchyma, right? Breath sounds are normal, but the key there is fine, late, or pan-inspiratory crackles over the affected lobes, which is affectionately termed Velcro-like crepitations because of the character of the crackles. How do we investigate different respiratory presentations, guys? So if we're thinking about infection, and then we have acute bronchitis, infective exacerbation of COPD pneumonia, good idea to get your chest X-ray, and you can define consolidation in pneumonia. Oxygen saturation of blood gas, why? Because you want to assess respiratory failure. Type 1, type 2 is hypoxia and hypercarbia respectively. Sputum and blood culture to look for an etiology in terms of infection. Respiratory function for quantification of any COPD, that's a lung function test. You look at the FEV1, FVC, and the ratio. Look at your total lung capacity and those parameters. Once I can't CRP, good idea because you want to assess the degree of inflammation. If you're thinking about malignancy, good to get a chest X-ray to ID a mass. CT scan of the thorax and abdomen looking at staging. Bronchoscopy is essential because you want some kind of histopathological diagnosis, or you can do a CT guided biopsy if it's peripheral. So if it's central, you can do bronchoscopy or EBUS, which is endoscopic bronchial ultrasound, or if you can do a CT guided biopsy if it's peripheral, right? Respiratory function, of course, looking for fitness for radical therapies. Good idea to get a lung function. If you're dealing with pulmonic fibrosis or interstitial lung disease, get yourself a chest X-ray. What you can find is bibasal reticular shadows, HRCT, high resolution CT, which doesn't require contrast, to determine and delineate the extent and type of disease. Lung function for quantification and identification of a restrictive pattern. And autoantibodies, especially with regard to connective tissue disease, because we know that lupus is associated with it, RA, rheumatoid arthritis is associated with it, poly and dermatomyositis associated with it, right? Even Sjogren's syndrome, even systemic sclerosis, right? The list goes on. Pleural effusion, get yourself a chest X-ray to determine your dense basal fluid pool, ultrasound guided aspiration, and for that we can send for Lyle's criteria. You can send culture for infection, find the pH is low in empyema, glucose is low in infection and in rheumatoid arthritis, cytology to ID malignancy, protein to see if it's a transudate or exudate, CT thorax abdomen if there's an underlying tumor. Pulmonary embolism, good to do a D-dimer. Remember, D-dimer is sensitive but not specific. So if it's negative, you can rule out a PE, but if it's positive, you can't necessarily rule in a PE, right? And do your Wells score, which is a predictive score, right, for a PE. Remember, D-dimer is normal if it's not a PE. CT pulmonary angiogram to detect the emboli. Echo will show you detection of right ventricular strain, oxygen salts and blood gas, assessment of respiratory failure. In terms of asthma, good idea to do a lung function, a peak flow diary to determine variability of obstruction, FEV1, of course, and reversibility to ascertain if this is indeed reversible obstructive airway disease, which is asthma, as opposed to COPD, which is poorly reversible. And the parameters we look there for is after you give a bronchodilator, improvement of the FEV1 by 12% or 200 moles. Oxygen saturation and arterial blood gas to assess respiratory failure. You want to do IgE and allergen skin tests for detection of allergic stimuli. All right, so a patient comes into you who's acutely dyspneic, right? What are you going to do when they come for you? Don't call bad boys. Good idea to triage the patient, right? Attend to the airway, breathing, circulation, etc., as per our ACLS and usual emergency protocols. Do an ECG, do a chest X-ray with or without a blood gas. Does the cause require immediate correction? Yes, then you address that, right? And you assess the effort and adequacy of oxygenation and ventilation. Is the underlying COPD? If yes, then you head down your NEBs and your steroids and that pathway. But if no, is there evidence of respiratory tract infection? If yes, then you monitor for infection. Your sputum gene expert, your sputum bacilli, put the patient into IV antibiotics and so forth. If no, are there clinical or chest X-ray features of heart failure? Right, then it means it's likely left ventricular failure. Consider acute respiratory distress syndrome. You're going to see an enlarged cardiothoracic ratio. You're going to see curly B lines, upper zone diversion. You're going to see effusions, etc. If no, if there's a generalized wheeze with a diminished peak expiratory flow rate, this is probably acute asthma. If no, is there any other diagnostic chest X-ray abnormality? If yes, it could be a pneumothorax, a pleural effusion, it could be lobar collapse or any other pathology. If no, are there ischemic ECG changes? This is likely ACS. If no, does the blood gas show a primary metabolic acidosis with a normal PaO2? If yes, consider diabetic ketoacidosis, salicylic poisoning, uremia, shock, cat mud pile. So you get a high anion gap metabolic acidosis, HAGMA, then you get a normal anion gap metabolic acidosis, NAGMA. If no, Is there clinical suspicion of pulmonary embolus or unexplained hypoxemia? If so, head the way of a CT pulmonary angiogram or a ventilation perfusion scan. Diagnose your PE. If no, and if you're still uncertain, seek respiratory input if there's hypoxia, hypercapnia, hemoptysis, or abnormal chest X-ray. Very important side note, if your patient's RVD positive, it's retroviral disease or HIV positive, with a low CD4 count, WHO clinical stage 4, and presents with hypoxia, always think of pneumocystis jirovecii pneumonia, PJP. Get your Bactrim, get your steroids on board. Okay, my friend. The book of Ephesians chapter 4 verse 25 says, therefore each of you must put off falsehood and speak truthfully to your neighbor, for we are all members of one body. Right? Do you know that the Bible describes the devil as the father of lies? And just as a father passes on his DNA to his children, you can determine who your father is by looking at your DNA. If you lie, the Bible says your father is the devil. God delights in truth, right? Therefore, Paul is admonishing the Ephesians, saying that we should put off falsehood and always speak truthfully. I pray that will be true upon our lives. Here are my references, guys. Thanks so much for joining me. I'll see you soon with another handy video in this series. God bless you.